So the correct answer is pleural fluid cytology for malignant cells. In the absence of a lung mass and in the presence of a pleural effusion, pleural fluid cytology with cell block preparation is minimally invasive and allows for both cytologic diagnosis and for molecular testing, including, if needed, NTRK fusion analysis. A bone biopsy could be considered if the pleural fluid is non-diagnostic, but this would be more invasive and is complicated by the requirement for decalcification of bony specimens in order to permit for histologic processing, and this step can interfere with molecular testing. Sputum cytology and bronchoscopic biopsy are less likely to yield diagnostic tissue in the context of the absence of a clear lung mass. So here's an image of the pleural effusion cytology. As you can see, this is a very densely cellular cytology specimen containing innumerable atypical cells, present as single cells and as small clusters. Immunohistochemistry was carried out on this specimen, showing that the tumor cells were positive for TTF1 and cytokeratin 7 and negative for P40, CK20, and chromogranin. These findings are consistent with a diagnosis of metastatic lung adenocarcinoma. Rapid targeted molecular profiling performed initially demonstrated that the tumor cells were negative for mutations in EGFR and BRAF, as well as for fusions in ALK and ROS1, and PD-L1 immunohistochemistry was negative. Subsequent comprehensive DNA-based next-generation sequencing was performed and showed the presence of a rearrangement involving NTRK intron 1 with an intergenic region on chromosome 4. The identification of the partner gene that was fused to NTRK1 was unclear, and ultimately from this information, it was difficult to determine with certainty whether there was indeed a functional rearrangement involving NTRK. No other mutations of biological or clinical significance were identified. The TMB was modestly elevated, and as you can see from the copy number profile at the bottom, there was a significant degree of chromosomal instability, as well as notably a deep deletion in the CDKN2A gene. So let's talk a little bit more about testing for NTRK fusions. The testing approaches that are accepted for detection of NTRK rearrangements from clinical trials that ultimately led to drug approvals include DNA and RNA-based NGS, fluorescence in situ hybridization, as well as reverse transcriptase PCR. Of note, for FISH in particular, in certain tumor types such as infantile fibrosarcoma, where the partner gene is consistently ETV6, FISH for that particular gene is acceptable as a surrogate for NTRK3 gene rearrangement detection. Just to comment further on NGS-based NTRK detection, when testing the DNA, the challenge is that most NTRK rearrangements occur based on breakpoints that occur within the introns. The introns in NTRK, where these breakpoints occur, in particular in NTRK2 and 3, are very large, greater than 100 kilobases, and these contain highly repetitive regions that are difficult to target using hybrid capture methodologies. This leads to limited utility of DNA-based methods, particularly for detection of fusions in NTRKs 2 and 3. The common breakpoints are highlighted by the blue arrows in the image to the left. In contrast, RNA-based strategies that target transcripts will detect only those expressed transcripts. And this particular assay can be designed with a very focused analysis of those exons where the expressed transcripts are likely to occur. Both hybrid capture or amplicon-based sequencing strategies can be used from RNA. In particular, anchored multiplex PCR is a widely used strategy, and this has been shown to have improved sensitivity over DNA-based testing. Multiple studies have demonstrated the superior sensitivity of an RNA-based strategy. Here is one study from the Memorial Sloan Kettering group that examines the sensitivity of their DNA-based impact panel relative to a combined approach examining both the DNA and the RNA. And as you can see from the table, the sensitivity is only about 80% for detection of fusions in NTRKs based on a DNA-only strategy, with a general inability to detect fusions within NTRK2. And interestingly, for fusions in NTRK3, most of those were detected based on targeting of the partner gene ETB6. So, in general, DNA and RNA-based approaches appear to be the most robust and sensitive for NTRK fusion detection. And a question a lab might ask is, do we need to perform comprehensive DNA and RNA sequencing in all of our non-small cell lung cancer cases? The benefit of this dual strategy is that it permits for a priori confirmation of both functional rearrangements and identification of non-functional rearrangements that can be detected in the DNA. This is, however, a more costly strategy as it's essentially going to double the cost of sequencing. And it also requires that a laboratory develop a total nucleic acid extraction strategy or another paired DNA and RNA extraction workflow. Other labs will implement a sequential strategy where you perform DNA NGS followed by RNA testing, particularly when the DNA NGS is negative. And you can argue that in most cases, particularly for lung cancer, which are driven by point mutations and in some cases copy number changes, RNA testing up front for fusion detection may not be necessary. However, this ultimately delays identification of fusion drivers that are going to be missed using DNA-based approaches. Single gene and small panel strategies are still feasible in some settings. Fluorescence in situ hybridization, it does require a cytogenetic lab setup. In addition, multiple probes are required to cover all of the fusions involving the NTRK 1, 2, and 3 genes. And it's important to remember that with FISH, the presence of a rearrangement does not necessarily indicate an oncogenic event because of the fact that FISH can or agnostically detect structural rearrangements. There's not an inherent functionality to any alteration that is seen by FISH. So molecular confirmation may be needed in some cases. And in general, this is a relatively expensive approach to screening. RT-PCR is a fast and inexpensive strategy. Its sensitivity, however, is limited by the scope of the assay when targeting defined gene partners. It does require a multiplex design, and there are a large number of 5' fusion partners that can be bound to NTRK. Finally, pan-Trk IHC is something that's readily used in a pathology practice. There's a number of clones that have been published, and some image examples from known positive cases are shown here in this slide. However, the performance of pan-Trk IHC relative to DNA RNA sequencing is inferior, both in terms of specificity and sensitivity. So any result from pan-Trk IHC should be confirmed using a reliable molecular method. In particular, we recognize that some well-defined sarcomas with alternative genomic alterations can have pan-Trk overexpression. Just to circle back to our case, our patient underwent targeted RNA-based fusion testing that confirmed the presence of a TPM3 NTRK fusion. He was started on entrectinib with progression after 10 months, then transitioned to larotrectinib with progression after 4 months, and then finally transitioned to chemo and immunotherapy. The patient survived 3 years from the time of his diagnosis. Just to wrap up, there are multiple strategies in existence for detection of NTRK fusions. DNA-based testing is challenged by large introns and the technical difficulty of NTRK rearrangement detection. Pan-Trk IHC should always be interpreted with caution and confirmed, and comprehensive DNA and RNA strategies are preferred for NTRK fusion detection. And with that, I am pleased to pass the stage along to my colleague, Dr. Paz-Arez, who will now be presenting on the management of patients with NTRK-positive non-small cell lung carcinoma. Thank you very much.